So by way of background, we know that previous genetic studies, called Mendelian randomization studies, have demonstrated that LDL cholesterol appears to be causally related to the risk of cardiovascular disease. And numerous randomized trials have shown that reducing LDL cholesterol reduces the risk of cardiovascular events by about 20% per millimole per liter reduction, largely independent of how we lower LDL cholesterol. The notable exception to that, though, are the CETP inhibitors. As you know, 3 previous CETP inhibitor trials have failed, and in fact, in the Accelerate trial, treatment with evacetrapib reduced LDL cholesterol by 3/4 of a millimole, but had no effect on the risk of cardiovascular disease. And that has caused many people to question the causality of LDL cholesterol, and it raises the possibility that the clinical benefit of lowering LDL cholesterol may depend on how we lower it. So with that background, we decided to create genetic instruments that mimic the effect of CETP inhibitors and statins and conduct a naturally randomized trial. The purpose of the study really was to determine whether or not lower LDL due to genetic variants that mimic CETP inhibitors has the same effect on the risk of cardiovascular disease as lower LDL due to genetic variants that mimic the effect of statins or ezetimibe or PCSK9 inhibitors, and thereby allow us to make those kinds of inferences as to whether or not how we lower LDL cholesterol really influences the potential clinical benefit. Well, it's interesting. So, CETP inhibitor inhibits the transfer of cholesterol esters from HDL particles into LDL particles as well as triglyceride-rich VLDL particles. And the genetic variants do exactly the same thing. In fact, they mimic the effect of the pharmaceutical precisely. And therefore, this allows us to construct a genetic instrument that mimics the effect of a CETP inhibitor and statins through separate genetic polymorphisms. What's interesting, though, is each of the variants are inherited randomly, which means that inheriting an allele associated with lower CETP activity is analogous to being randomly allocated to a CETP inhibitor, while inheriting the other allele is analogous to being randomly allocated to usual care. Because the allocation is random, we can then follow patients forward in time and make unconfounded causal inferences about the effect of CETP inhibition on the risk of cardiovascular disease in a manner analogous to a long-term randomized trial. So somewhat ironically, the study has very little to do with genetics. The genetic variants we use are merely convenient instruments that mimic the effect of the medicines and allow us to randomize people to higher or lower CETP activity. So we studied a total of 358,000 people who experienced 76,000 different incident coronary events, or first coronary events. And what we found is that when we considered CETP inhibition alone, the CETP inhibition was associated with lower this genetic CETP score was associated with lower CETP activity, which in turn led to higher HDL cholesterol, lower LDL cholesterol, concordantly lower ApoB, and a lower risk of cardiovascular disease. In fact, in dose-dependent analyses, increasing CETP inhibition led to stepwise increases in HDL, stepwise decreases in LDL and ApoB, and a corresponding stepwise decrease in the risk of cardiovascular events. Importantly, however, when we then compare the effect of the CETP inhibitor score with scores that mimic the effect of statins, ezetimibe, and PCSK9 inhibitors, they had exactly the same effect per unit change in LDL cholesterol, implying that it doesn't really matter how we lower LDL cholesterol, it's the magnitude of the benefit. Now that is inconsistent with particularly Accelerate. So what we did next was then we noted that all of the previous CETP inhibitor trials, including the REVEAL trial, which was also reported at this meeting, evaluated the effect of CETP inhibitors on the background of statin therapy. So we constructed a second genetic score that mimics the effect of statins and evaluated the separate and combined effect of CETP inhibition and HMG co-reductase inhibition. And when we did that, we found something quite interesting. When CETP inhibition is considered alone, it leads to concordant changes in LDL cholesterol and ApoB and a lower risk of cardiovascular disease that's proportional to either of those. By contrast, when CETP inhibition is added to HMG co-reductase inhibition, like adding a CETP inhibitor to a statin, it leads to discordant changes in LDL cholesterol and ApoB due to an attenuated change in ApoB, and the risk of cardiovascular disease is proportional to the attenuated change in ApoB and less than expected per unit change in LDL cholesterol. And to validate that, we then did a genome-wide association study and found 21 variants that had naturally occurring discordance between LDL and ApoB, and that score, once again, associated with the risk of cardiovascular disease proportional to ApoB, rather than, was significantly less than the expected benefit per unit change in LDL. So what we conclude from those data is that the causal effect of LDL on the risk of cardiovascular disease is determined by the circulating concentrations of LDL particles as estimated by ApoB, rather than by the cholesterol mass carried by those particles, which is what we measure by LDL cholesterol. So what we conclude from these analyses is that the causal effect of LDL on the risk of cardiovascular disease is determined by the circulating concentration of LDL particles as estimated by ApoB, rather than by the concentration, the cholesterol mass carried by those particles, which is what we measure by LDL cholesterol. Now that's important clinically because what it means is that the benefit of an LDL cholesterol lowering therapy is determined by the corresponding absolute reduction in LDL particles, which in turn means that it appears that the clinical benefit of lowering LDL cholesterol does depend on how we lower it. Therapies that reduce LDL cholesterol by reducing LDL particles should reduce the risk of cardiovascular disease proportional to the absolute reduction of either LDL cholesterol or ApoB because they're concordant. Therapies like statins and PCSK9 inhibitors and ezetimibe. By contrast, therapies that reduce LDL cholesterol by altering the lipid content of particles without proportionally changing the concentration of LDL particles, like adding a CETP inhibitor to a statin, reduces the risk of cardiovascular events proportional to the absolute change in ApoB, which is less than one would expect from the absolute magnitude of the change in LDL cholesterol. And so these data, in some sense, explain the ACCELERATE trial by showing how evacetrapib can robustly lower LDL cholesterol without reducing events because it had a substantially attenuated effect on ApoB and only lasted 2 years' time. And in addition, it anticipates that treatment with anacetrapib in the REVEAL trial will reduce the risk of cardiovascular events proportional to the absolute reduction in ApoB, which may be less than the expected benefit per unit change in LDL cholesterol, depending on the degree of discordance that occurs between LDL cholesterol and ApoB when anacetrapib is added to a statin. This study has implications for evaluating any number of different novel therapeutic agents. What we know is that novel therapeutic agents that, like ApoC3 inhibitors or ANGPTL3 or ANGPTL4 inhibitors or others, or even the new fibrates in development, that alter the lipid content of LDL or ApoB-containing lipoprotein particles without proportionally reducing the number of particles, they are likely to reduce the risk of cardiovascular events proportional to the absolute change in ApoB, not necessarily the change in triglycerides or the change in LDL cholesterol itself. And so, as a larger implication, this new approach to using genetic instruments to mimic the effect of medicines and conducting naturally randomized trials has implications for drug discovery and development. It may be one strategy going forward that if we're interested in evaluating a novel therapeutic either within the cardiovascular medicine space, within the lipid space, or blood pressure, or the cardiometabolic space, including diabetes, we can first construct an instrument, a genetic instrument that mimics the effect of that medicine, conduct a naturally randomized trial, and then anticipate what that trial will likely show in the actual trial in order to improve the design. And in fact, I would go so far as to suggest, as biopharmaceutical companies increasingly begin to focus on developing therapeutics that mimic the effect of causal mutations, in the very near future, many randomized trials evaluating those therapies will be designed to mimic or recapitulate the evidence from these naturally randomized genetic trials.